For those of you who've read ahead, you know this is a reflex point for the quadratus lumborum, so I won't quiz you on that. But how strange, lung 10 is a reflex point for the back. And this is another meridian that you will learn to love. And it's in very close proximity to the thumb. This is specifically at the abductor pollicis brevis. The point is where the skin texture changes. It's not dorsum of the hand anymore. It's not the palm. It's right at the area where that skin texture, and sometimes the color is there's a change there. So it's right at that line, and it goes right into the meat of that muscle. So that's the reflex point on the lung meridian. And what we're treating is quadratus lumborum. So quadratus lumborum is such an important muscle for back pain. A lot of times people have a little leg asymmetry or a little postural asymmetry. And it looks like they even have a little curve in the spine, but it's a soft curve. It's a curve that's flexible and can be addressed by releasing this muscle. And I included two different pictures on this slide because I think this is a fascinating muscle. It's got fibers that go from the ribs down to the vertebrae. It has fibers that go from the ribs down to the iliac crest. It has other fibers that go from the transverse processes of the vertebrae down to the iliac crest. So there's a lot of complexity going on there. And it's deep to the paraspinal muscles. So a lot of people that want to treat back pain, they get their hands on the paraspinal muscles and they think that's it. And then they try to treat the paraspinal muscles and they fail. And it's because they are not necessarily taking into consideration what's beneath there. And this QL area is really vitally important. The other illustration on this slide is on the right side, and this is from the Travell Bible of trigger point work. And when you have trigger points in the quadratus lumborum, the pain is often referred to other areas. So somebody may come to you with butt pain, buttock pain, pain at the greater trochanter, and you think, oh, it's just a greater trochanteric bursitis. Could be referred pain from QL. Look at that picture carefully and notice that there's even a referral to the anterior area. So is that McBurney's point? Is that person needing an appendectomy? Oh, maybe not. Maybe you could treat their quadratus lumborum and that could relieve some local pain. So remember some of these referral patterns that have everything to do with the fascial connections. And what you're learning now is that you can put in a needle right to the surface of the fascia and really create quite a change beneath there. This is just another drawing of where lung 10 is. It's the first metacarpal bone midpoint at that border between the dorsum and the palm. And that is the reflex point, and here's your sequence. And this is the same sequence we've been learning right along. Patient says, oh, my back hurts. You examine them. You decide that they have tenderness or tension at the quadratus lumborum. You press your finger into lung 10. You repalpate. See if it changes. If it changes a little bit, you say, well, that's good enough. I'm in the right place. Then you can needle it. Palpate again. Some more release. Now you really want to go for it. Adjust the needle to exactly the right position and go for a complete release. Now because this is torso and it's postural, again, this is very often bilateral, so make sure you check the other side. And we're going to practice. Everybody okay with going to practice? Well, demo, yes.
Is there a specific direction?
This one just is pretty perpendicular. And fortunately, we don't have to worry about lungs and bones. You stay palmar to the bone, and you can go quite perpendicular and adjust it as needed. So if you don't get the release you want, you can pull out just a little bit and then reinsert in a slightly different angle, see if it makes a difference. It's not unusual to actually get a myofascial release at the thumb, which patients find to be rather uncomfortable, but they're really grateful when they realize that that also released their back. So be aware, this is a pretty sensitive area. This is why we didn't do this one first. All right, so I'm going to demonstrate on our favorite patient, Alan. Now you may wonder, why do I keep doing this to Alan? You see, when someone has one particular problem, it can lead to other things. If I want him to have complete relief of either inguinal tenderness or low back pain, I want to make sure every one of these things is addressed. one thing can lead to another. In fact, at my first group, they even noticed when they squeezed the calf, that needle up at bladder 25 moved a little bit. So if somebody has pain at their back, the calf, everything else comes into play.
I have left back pain, Doc. Goes to my iliac crest.
Seriously? Jeez, Alan, what a mess. You're a mess. All right, so how do I find the QL? I identify where's the iliac crest.
Ooh, that's Tim.
Oh, jeez. Where are you not tender? And it's actually a fairly short segment on most people, unless you're, I don't know, I guess a Victoria's Secret model. Those people they're strange. They're very strange, long torsos. But most people, is a relatively short segment here between the iliac crest and the ribs. So you identify where that segment is. And remember, we're not trying to palpate the paraspinal muscles. We want to go lateral and really kind of press in there and see if that's a tension area. And it certainly feels tense to me. All right, so I'm going to press there. And I say, well, that's kind of tight. He feels that it's tight, and I feel it's tense. Using the ipsilateral lung 10, I'm going to identify, there's the metacarpal, midpoint of metacarpal, and I'm just going to press on the abductor pollicis brevis. Okay, now, as I'm pressing on the abductor pollicis brevis, I'm releasing at the quadratus lumborum. Give it a moment to work, come back, press the QL, see if it's changed.
It's slightly better.
Okay. Let's go for more better. I'm going to move a little bit at the thumb.
That is better. It's
still kind of there. And that's good enough for me, because what I'm going to do now is I'm going to insert the needle at lung 10. I need to make sure that this patient's arm is secure and isn't going to flop off the table. And a needle in there. And then I'm going to come back and see how that QL does.
It is better. I feel more pressure.
And I'm pressing pretty darn hard in there. And that's really all it is. I could do the other side, but I think you should just go to your tables and practice.
How long do you leave the reflex point?
The reflex point, like any one of these modules that we're going through today, you can just needle it, take it out, and be done with it. And that's a treatment if you're having a very busy day and you can't fit anything else in. That's the beauty of this style, is that the needle can just go in and come out and you can be done. Or what I would really prefer to do is take into consideration all the other different acupuncture treatments that I can do. I may want to do an ear treatment now. You can do an ear treatment on a prone patient. They don't have to be seated in a chair. I may want to practice my scalp acupuncture on him. I may want, once it's softened up and receptive, I may want to needle locally in here. So the treatment can be as short or long as the patient needs and you're able to do. Look at that. We have another reflex point, and Mr. Smarty Pants over there probably knows what this treats. Oh my! Oh! but first, kidney 7. My goodness, we've covered bladder and stomach and lung. Now we're on the kidney. Kidney is in relation to the medial aspect of the leg, and kidney 7 is a beautiful point. And there's a very specific way to find kidney 7. First, you identify medial malleolus. Everybody go ahead and palpate your medial malleolus. You go, yeah. Ankle bone, remember that? Okay. Back behind the ankle bone, there's an Achilles tendon. All right, so you stay in front of the Achilles tendon, because we don't really want to needle the Achilles tendon. We want to stay in a little soft, indented area anterior to the Achilles tendon. What you do is you slide your fingers up just a little bit until you reach a valley, a dent, a hole, an area that is just saying, I really want you to needle me, okay? That's kidney 7, okay? Bodies will talk, you just have to listen, really.
Slide, don't poke, just
slide up.
Find the first big hole at 3 and then slide up. You'll fall into another hole.
Okay. And we'll do this at the table so that you know exactly where kidney 7 is. Now, I've been mentioning to a few folks, and so I want to say it to the whole class, we're teaching you acupuncture points, and these really are acupuncture points. So you're getting a new familiarity to these various meridians and specific points. For this style of acupuncture, remember, we're influencing the fascia, and so we're identifying the point, and then we're also understanding that it's a zone. It's wherever around and near or on that point that works for this person. So that's the reflex point, and we're treating transverse abdominal muscles. This picture of this lady in a blue tank top here is an example of how to check transverse abdominal. There's a lot of different ways. You can just palpate transverse abdominal muscles and find a tender point. Or you can ask somebody to sit in this position. Think of the elbows as little flags. Those flags are telling you where the restrictions are. So what I'm asking this patient to do is rotate at the torso, rotate at the abdomen using the transverse abdominal muscles, and then I watch how far the elbows can move. So how far those elbows move is easier for me to see than how far the abdomen is moving. Okay? So if she rotates to the right and then rotates to the left, and I observe, oh, she's not rotating as far to the right. It seems like she's just not able to move very far in that direction. That indicates to me that transverse abdominal muscles on the left are restricted. Okay? So I want you to read that carefully. If the movement to one side is limited, that indicates a restriction of the transverse abdominals on the opposite side. Is that understood? What do we want to treat? We want to treat the side that the transverse abdominal muscle is restricted. So if she doesn't move as far to the right, that means there's a limit on the left. That means we treat kidney 7 on the left. Okay? If she cannot move as far to the left, that means there's a restriction at the right transverse abdominals. We treat it with using the reflex point kidney 7 on the right. Is that clear? It will get clearer when you do it. The idea is to get the concepts down, then I'll demonstrate, and then you'll do it yourselves. Same sequence. Observe for movement restriction. Now, patients hardly ever come in and say, oh, doctor, my aching transversus abdominis. In fact, I don't think anybody's ever said that to me. But
Alan has said it to me quite recently.
Alan has said it. Alan's kind of a mess. Now, we're kind of picking on Alan right now, and he probably deserves it. But nevertheless, when patients have had abdominal surgery or they walk funny, let's say you broke an ankle and you're limping around on one leg, and so there's asymmetry and there's rotated pelvis, you can start to see where all these things start to come into play. So maybe after walking funny in a boot and non-weight bearing, the calf got kind of tense. So you can start to see where, oh, let's release the calf. Now we can palpate the back better. Yeah, we release the back, but I think the psoas is involved. So let's flip them over and see how that inguinal, that inguinal area is really tight on one side. You can see how these tie in together. Now, if Alan has more inguinal area tension on the right, on the left, you can imagine that he also might have transverse abdominals, these twisting torso muscles, they also might be restricted. So we're not just, well, we love picking on Alan, but nevertheless, we're not just picking on Alan. This is real life. People don't just have one muscle involved when they have pain. They have an array of muscles. So it's your job to examine them and then think not just about static anatomy as you learned it in medical school, but the dynamic anatomy of how someone moves. All right. So back to the sequence. Observe, listen for what the pain complaint is. And this may be a pain in the pelvis, could be a pain in the groin, could be a pain in the back. It could be just, I don't know, doc, I've been shoveling snow. This is a New Hampshire problem. Shoveling snow a lot, and I just shovel in one direction, and now I've got this pain in my torso. My core strength isn't what it used to be. So use the maneuver to observe. You may actually palpate mid-axillary line. Drop down a plumb line from the middle of your armpit, in case that was too many big medical words for you. Mid-axillary line, palpate right below the ribs, right above the iliac crest. For some of us, that's exactly the same point. Not a lot of room to move in there. That might be tender in there. So you look at their movement, you palpate them, and you say, oh gosh, there seems to be a problem with transverse abdominis. You go to kidney 7 on that side, use the same sequence. Push with a finger, pretend your finger's a needle, repalpate, put a needle in, repalpate, adjust until you get some response. Okay? That's just the same thing. Before I demonstrate on Alan, any questions about this one? All righty, Alan is now going to put his hands behind his head, stick those elbows out, and now rotate the best you can. Now you're not asking the arms to move, you want this to stay as a unit, and what are we observing? I'm seeing a restriction. I need to get right in front. Am I in the, oh, we're not going yet anyway. Okay, go. Okay. All righty.
Okay, it's coming up on screen, so maybe do it again.
Until you can't do it anymore. Tina, what are you seeing?
At first, I was seeing restriction towards that direction, but then near the end, it looked like it changed. 'Cause he's kind of compensating also.
Yeah.
I'm thinking he's not moving as much to the left as the right.
That's what it was looking like at first, yeah.
Yeah. So what I do with that, and these are a little sketchy, it's really harder to only look at the torso. This kind of helps you, look at these flags waving. We should put big flags out on your elbows. But the other way I do this is by just, and I'm just going behind him because it's a class, but come in here and say, well, mid-axillary line between the iliac crest and the ribs. Ooh, it's really tense on the left. Yeah. It's way more tense on the left. All right, so we're going to treat the left. Everybody good with that?
Yes.
Is Alan left-handed or right-handed?
What do you think? Left-handed. All right. So I feel the tension more on the left, so I'm going to treat kidney 7 on the left. What I do, there's his foot. Woohoo! That was wild, Alan. Okay. There's his foot, there's his medial malleolus. My finger's on the peak of the medial malleolus. I go sliding back until I reach the Achilles. Okay? And I'm in front of the Achilles. Now I slide up until there's a little hole. And actually, I'm not really paying attention, so I'm going to do this with my dominant hand. It's right there. It is right.
That's how she's sliding from one hole to the
Right
next.
there.
That's the accurate palpation for acupuncture. They're not measured.
See, Alan was helping me too much, so I'm getting his whole leg to relax now. Because if I want this point to send a message up to his torso, it's helpful if his muscles are not tense. All right, so his leg is nice and loose and relaxed now. So medial malleolus, back to the Achilles. In front of the Achilles, slide up. And I've now created a little dent there. And I want to come back to his,
Under his foot there.
yeah. Relax. Alan's being way too helpful here, so yeah, he doesn't have to do anything. I'm going to go back into this point between the ribs and the iliac crest in the mid-axillary line, and I'm just going to feel how tense it is. It's right there. Owie?
That's tender.
Okay. Now I'm going to simulate a needle with my finger at kidney 7, and then I'm going to go back to that tender point and see. Still tense.
Still tense and
So I'm going to readjust here.
40% better.
I'm going to readjust with my finger down here. I'm going to push up here. It's
That's
a little
more
better. And that is good enough for me for right now because the needle's going to do the rest of the work. This needle is going to go in, pointing upwards a little bit. Again, in front of the Achilles, just under the surface. And then I'm going to come back up to here. See how that feels?
It's mostly just pressure. It's a little tightness.
Tense
but-
right there.
Yeah.
All I'm going to adjust.
It's not really as sensitive as it was.
And it's definitely softer. Now let's see how the motion goes and see how easy it feels. Go ahead.
Oh, that's a lot easier.
Good.
I notice a difference when I do.
Alrighty. You know, when I first learned acupuncture, I learned that kidney 7 was a great point for back pain. So I just memorized kidney 7 is a great point for back pain. Now I know why. There's a lot of reasons why, but this is one of the reasons why. See, he can move his torso better, so that's going to help his back as well as all of his core movements.
And everybody knows I need all the help I can get.
Yeah, we got to keep this guy going. Ha! All right, so kidney 7, you ready to practice?
Question here.
Boop, 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 boop. Question. Yes. Yeah, and we were actually not entirely clear which one was limited when he was rotating. So I resorted to the palpation method. If it's clear, like, wow, I can rotate all the way to this side and this side, not at all.
So if you can't rotate that side, then you're treating.
So if I cannot rotate to the left, the restriction is over here on the right, and I treat it with a right kidney 7. They were pretty close. It didn't become obvious to me until I palpated in there and I went, oh, clearly it's more tense on the left. So there's really 2 ways to do this one. Okay, does that make sense? And we can make more sense in small groups. So small groups. This is simple, but I didn't say it was straightforward, did I? All right. We talked about bladder 25. Remember where that was? L4, it's on the back. The bladder channel is the back side of the body. Now we're going to learn 3 reflex points in a row. And we're going to start with bladder 40. Bladder 40 is the first of these 3 bladder channel reflex points along the back of the leg. Hey, Dr. Helms. Jeez. That's awesome. Usually he does that to me. Thank you. Thanks for doing that so I can feel okay now. Bladder 40 is at the popliteal crease. It's midway between the hamstring tendons. So medial is your semimembranosus, semitendinosus combination. Lateral is biceps femoris. Midway, right over the popliteal pulse, that's bladder 40. Next one you need to learn is bladder 60. This is lateral malleolus, midway between the bone prominence and the Achilles tendon. That's bladder 60. The third point we want you to know, remember these are all 3 reflex points. Bladder 58 is in the third depression when you slide your finger up from bladder 60. So you might feel a little dip, it's the third dip. If you don't feel these, it may be because you haven't developed your palpation skills just yet. So don't worry about it. We'll guide you through it when we get to the tables. This is for paraspinal muscle spasm. And the reason paraspinal muscle spasm gets 3 points is because paraspinal muscle spasm includes a long territory, anywhere from the very base of the neck right down to the sacrum. And so depending on where someone's paraspinal muscle tenderness, pain complaints, or spasm is, we zero in on one of these points. So if it's the low back, you zero in on bladder 40. If it's the neck, you zero in on bladder 60. And if it's mid-thoracic pain, it's bladder 58. And here's the great news. Remember, these are zones. So if you don't find exactly where bladder 58 is, don't worry about it right now. Remember, it's a zone. So get in the area, get in the neighborhood, and then start palpating and see what works for that patient. There's very seldom a patient who has isolated low back pain without some tension or tenderness or asymmetry up higher in the spine. So even if someone says, oh, doc, I just have low back pain, my neck is fine, palpate the whole thing. And what we're going to lead you through today is needling all 3. Because if you have low back pain and you needle 40, job's done, that's great. But you're going to do a better job if you needle all 3. Does that make sense? Kind of like the neck bone's connected to the low back bone, right? And either everybody's asleep or yeah? Got it? Tina, you got it? All right. Carol, got it? All right, good. Whew. All right, bladder point needling. This is what I just said. Bladder 40 used primarily for lumbar pain. Angle the needle inferiorly. So you enter at that midpoint between the tendons, you point the needle towards the foot. For bladder 58, it's a zone. This takes care of the mid-back. If it's upper mid-back, you go lower. If it's lower mid-back, you go upper. Try to think of the body folded upon itself. So if you think about this segment of the leg, with the low back being at the knee and the neck being at the ankle, you can imagine that that zone of bladder 58 would correspond. Does that make sense? Okay, thank you. Bladder 60, this is used primarily for the neck. That one is angled superiorly. Now, we have reasons behind all this, but again, I don't want to flood you with information, so at this point, it would be helpful if you trusted what I'm saying to you. So point inferiorly for 40, point inferiorly for 58, point superiorly for 60. We'll reinforce this with hands-on at the table. So here's the sequence. Palpate for tenderness and tension at the paraspinal muscles. You find that there's tension and tenderness at the low back. You press your finger in at 40. You repalpate the back. You decide you're in the right point. You needle it. You adjust the needle. You release the low back tension. Same thing for 60. Same sequence. I don't have to read you slides. You can read these on your own. Same thing for 58. Okay? And then we practice. Before I demonstrate on Alan, any questions on this? This gets a little murky for people sometimes, and there's nothing like the hands-on to reinforce the information. So,
The order you gave us, is that the order that you suggest we needle?
the order in which you needle is based on the presentation of your patient. The reason I put it in that order is because at this stage of your learning, it's easy to learn where 40 is, because you know the anatomy behind the knee. It's easy to learn where 60 is, because it's right in relation to the ankle bone. It's harder for you to understand where 58 is, so that's the reason I put it in that order, because we are identifying bladder 58 point by sliding up from bladder 60. Well, how do you slide up from bladder 60 if you don't know where it's bladder 60? So that's the reason I put it in that order, but you tailor your palpation of reflex points and your needling of the reflex points based on the presentation of your patient. So, for example, if a patient primarily came to me with mid-thoracic pain, I would start right at bladder 58. If I released bladder 58 and then decided that, oh, that low back is pretty I might then go to bladder 40. We noticed at our table with transversus abdominis, once we release one side, it's sort of unsheathed or unroofed. Oh, the other side is, yeah, that one's a little tender now too. Now that the other side feels good, yeah, that side needs it too. Okay, great. So once you release part of the paraspinal muscles, you might find other information that that patient didn't even realize they had because it was overshadowed by their primary presentation. Okay? Shall we see what Alan has? Poor old Alan. He's got some back pain. Alan, is it more neck, more mid-back, or more low back?
It's all on my back and my neck and my butt.
Oh my God. All right. Well, he does. He's a lot of help. All right, so I'm just going to start by warming up my hands on his back and getting a sense for how tight these muscles are. Now, I'm a little more midline than I was for the quadratus lumborum.
You think we should call this treatment DNR rather than PNR?
Ooh, it's good thing you guys go way back, huh? My goodness. So there's a ropey band if I ever felt one.
Yeah, I told you I needed help.
Jeez. So I do like to start with low back just because those muscles are so darn big, and if you can release those, you get better results up higher if this is a area where all three are involved. So I'm going to start with this here. I can feel the tension there. How does it feel to you, Alan?
It feels tight, a little uncomfortable.
Okay. Now let's look down at the popliteal fossa. So we've got tendon and tendon. We've got popliteal crease, and here's the midpoint. This one points inferiorly. This is a needle that points, so I'm using my index finger to pretend that's a needle, and I'm going to push in there pretty hard, pointing inferiorly, let it work, come back to the lumbar paraspinals, and it still feels tight to me.
It's less uncomfortable though.
All right, I'd like a little better result, so I'm going to just move over a little bit. Oh, that's,
Oh, I felt something there.
that worked. All right, I'm keeping my finger in place, and I'm going to stare at the point until I know where I am, and then I'm going to place that needle. Now, this stuff works. It's so cool. How was that, Alan? Is that good for you?
Basically what I'm feeling a little bit of tightness, but basically I'm just feeling the pressure of your fingers.
All right, I'm going to get fussy. It's definitely not as tight.
Yeah, it's definitely different. Very much less of a discomfort.
Unlike the order in which I taught you the points, 40, 60, 58, I'm going to move up his spine and go now to this tight place at the mid-thoracic area, which was definitely a ropey band there. And what am I doing? I'm losing my needles. And I'll show you where the bladder 58 is. We go from lateral malleolus. Is everybody getting nauseated now? Ooh. Good. So what I have is one finger on malleolus, one finger on Achilles, just so you know where I am. All right. The point is, bladder 60 is between those two. I'm sliding up. I can feel a depression there. I can feel it, well, that's the sock line. And bladder 58 is right in there. And so now, I need to reach. Is that uncomfortable?
No.
It's
I
not.
still feel tightness on my back.
Okay. So it's definitely a ropey band. So now what I'm going to do is I'm going to dig right in here. Oops, I'm pushing in the other direction. I'm pushing inferiorly. Come back. And it's still pretty tight there. So now it's still pretty tight, and so I'm thinking this is low thoracic. So do I want to go higher or lower with bladder 58? Higher. Thank you, Tina. Try that. It worked. It's not as tense. How does it feel?
Yeah, it feels better. It's still a little tight.
Well, why don't I move a little bit lateral? Push.
Slightly better, but close to the previous one.
All right, now what I'd like to do, I'm definitely getting a response, so I'd like to just simply refine it with the use of a needle. So I got the needle in at bladder 58 zone. Come back to where I want to go here and adjust the needle until Alan says, hey, that's great.
Hey, that's great. It feels less tight. Still a bit of tightness, but definitely different.
Okay. You can do multiple needles in this zone if you believe that there's multiple levels involved with this tension. For the purposes of demonstrating, I'm simply going to move on to neck. Now, how do I do this? I'm going to try to reach. I can't reach. One way to reach is to bend the knee and do it that way, but I've already got needles in here. So that would be a compelling reason for it. If you were only treating neck pain and you just wanted to use bladder 60, you could bend his knee and treat it that way. But I'm not going to do that because I already have needles in. So what I'll do is I'll just go back and forth. Right there.
That's tight and sore.
Tight and sore. Okay, I can find that again easily. I'm going to push here. Actually, can I do that now? I can't do this I apologize. If you were just treating neck pain, you would need to do this with the knee bent. I can't do that right now. So what I'm going to do is what's that? That would be a way to do it. Tina's our lovely volunteer. I could do the other leg, but Tina's awesome. So he was tender right there. Feel that
Yeah, a little
rope?
bit higher, right in there, a little bit flatter. That's it.
Yeah. All right, so what I'm going to do is I'm just going to press. You tell me when you get some change. Repalpate. Maybe I'll move over a little bit. Remember, I'm just in front of the Achilles. I want to point upwards. So let's
A little
do.
bit softer.
All right, so a little bit softer is fine. I'm going to needle pointing upwards. Let's see what you got. Adjust.
I definitely felt a difference when you put the needle in. I mean, it's still a bit tight, but it's
Not
definitely
as
a change.
not as tender.
Well,
tight
it-
right here, but
Yeah, it's more tight than tender.
Okay. All right, so you get the idea, and this is something that, you know, I do apologize. I could have started just with neck, folded his knee up, and then just pressed in neck and do that, because I don't have a helper in my office doing this with me, so I should do that. But I wanted to start with low back because I felt like that was going to make more of an impact for him. Okay, so we have bladder 40 pointing down, bladder 58 pointing inferiorly, and bladder 60 pointing upwards. Generally, we do these both sides because it's very unusual for somebody to have paraspinal tension just on one side. Okay? Any questions about that? Ready for practice? Yes. All right. Oh. You're leaving, they're good. Last section, everybody ready? I am going to start by answering a couple of plaguing questions that have come up. One is this timing idea. I mentioned earlier that you could simply put a needle in, take it out, and you have treated someone. That is true, and that's not generally how I practice. Generally, how I practice is I release the calf tension first. Now I have access to bladder 58. Now I can use bladder 58 to address the paraspinal muscles. So I think about the entire sequence of what this person needs. So truly, one needle in, release, take it out, you're good to go. That's a nice quick treatment. That's not really being a thorough practitioner. So the timing could be anywhere from a minute to an hour. So what I do is I take these sequences that you're learning and I thoughtfully put them together for this individual. The classic really is bladder 25, release the calf. Now the calf is soft like butter. Needle, bladder 58. Now you've treated their paraspinal tension at the thoracic spine. So you can see where these really do go into sequence. After only one day with us, you can also think about that sequence you just did. That can get rather elegant. Bladder 40, bladder 58, bladder 60, bladder 58 zone, the entire spine. Do auricular. Now you can add on auricular to what you've done to release their back pain. So you can combine these things. You're going to be learning layer upon layer upon layer, from the most superficial to very deep treatments, and you can sequence these treatments and create a rather elaborate array of approaches for that individual. Does that make sense about the treatment timing? Okay, another question that has come up a couple of times, so I just want to touch on it very briefly. How is what we're doing different from dry needling? Dry needling is becoming a very popular term, particularly amongst physical therapists who have rather brief training. What they're taught is there's a tense, tender point, you stick a needle in it, you dry needle it until you release the tension, and then the patient's treated. What we're teaching you today, I think, is much more sophisticated because you're not putting a needle right into a tender area, so you're not aggravating that area. The patients who come to me after they've tried dry needling because they don't like it have been aggravated by the dry needling. because this uses a remote reflex point, you can treat them much more kindly. Once that area is softened, then you can go to the local area. So I want to make this distinction between a popular term that's becoming more and more popular and what we're learning is really much more elegant and sophisticated. Does that make sense? Okay. Just wanted to clarify those things. And now our last round is gallbladder 31, reflex point. Gallbladder zone is your lateral zone. You've already learned that stomach is the front, bladder is the back, gallbladder is your lateral zone. When you stand in a relaxed posture and reach your hands down to your sides and your fingertips touch the sides of your thighs, that's where gallbladder 31 is. It's in the IT band area, okay? It is to treat piriformis muscle spasm. Piriformis muscle spasm may look like a difference in rotation of the leg from one side to the other. There may be local tenderness, and the piriformis may also be affecting the sciatic nerve in such a way that the patient believes they have sciatica, when the nerve is actually fine if you would just release the muscle tension that is around that nerve. So again, instead of sticking the needle right into the piriformis, we can utilize gallbladder 41 to release the tension at the piriformis. Some people mention they have some SI joint problems. You can relieve SI joint problems by releasing the piriformis. Same treatment sequence you've learned, you've got this memorized. You palpate, you listen to the patient's problem, you observe them, you examine them, you push on the gallbladder 31 reflex point. All right, so what we're doing here is we're determining first where the piriformis is, second where the gallbladder 31 is, and now he may relax wherever he wants to relax. All right, so the way I find piriformis is I go to, okay, I need to, can't really see.
I did want to moon the class.
It's a half moon. It's just a half moon. Do you want more? I mean, this is really about you, Alan. So what I do to find the piriformis tender points is I go to the sacral hiatus, the little gap between the sacrum and the coccyx. I draw a lentil, or actually draw a line, between there and the greater trochanter. In this zone in here is where you find the piriformis trigger points. One is generally right in here.
Can you describe how you got there again?
So there's a line from the sacral hiatus, the sacrococcygeal junction, out to the greater trochanter. So envision this line here. Cut it into thirds. 1/3 of the way out, 2/3 of the way out. And then I start poking around deeply with my thumb, and I determine, is there a tender point in here?
Yeah, the higher you go up.
So right up in there?
Yeah, go a little higher.
A little higher?
More there.
More there. How about out lateral? In here?
No,
Not so much. In there? Not so much. Okay, so this is his most tender point.
maybe probably a little bit higher.
A little higher.
Yeah, there.
Okay, right there. So we've got the tender point, and now I have my finger on what I previously identified as gallbladder 31, lateral thigh, where his fingertip touches the thigh, gallbladder 31. So what I'm going to do is not trip over the wire here. Push my finger at gallbladder 31, go back to the tender point at the piriformis.
Definitely less so. The ITB is more uncomfortable than the piriformis.
All right, so rather than continuing to bother his IT band, I'm just simply going to get that needle in there. And then remember, I can go back and adjust as needed. So I was up here. Is that where I was?
Yeah, more there.
More there.
Still sore.
And so I adjust gallbladder 31. I palpate the piriformis. I'm pushing it about as deeply as. And then I adjust the needle.
Better.
And I don't think I can push any harder. And if it's not perfect, It's fine. I can go and do some auricular or do some other things that you're going to be learning to help his piriformis muscle. Does that sound good?
Were you just advancing gallbladder
I was.
one, or were you moving it in any other fashion other than just?
Great question. What I do is I just kind of explore this angle, that angle, this angle, that angle. When you do that, you're influencing the fascial planes. So remember, we talk about points, they're really zones. Move it around, move it around, move it around until you get the best result. You may want to go deeper, you may want to be more shallow, you may just change the angles a little bit. So you're just exploring that person's, remember the IT band can be very adhesed, can be a lot of adhesion and scar tissue and tense stuff in there. So sometimes I'll even put a second one in because I can get more response and more release, especially if up proximally here, it's not only the medial but also the lateral tender point. I may use a second needle at gallbladder 31 just to get more release.
You have to come out of the fascial plane completely before you actually can change the angle of the needle. You can't be deep into the fascial plane and think just because you took the handle and bent it down like this, that now somehow the tip of the needle is going in that direction. So if the tip of the needle is going like this, and you take the handle and move it down like this, the tip of the needle is not going to go up like that. It's just going to bend, right? Because it's just a needle, it's flimsy. So you have to take it out of the fascial plane, redirect it, and then insert it back into the fascial plane to do what Freda was just doing.
Yeah, we had talked about that at one of our small groups, and I mentioned that eventually you develop almost a proprioceptive sense for where the needle is. And when you withdraw it, like Ali said, you want to get it out of the fascial plane, but you don't want to pull it out of the skin because it's getting it through the skin that you do quickly. And we'll show you other needling techniques tomorrow that are really nice and actually much nicer than using tubes. And so we develop these nice insertion techniques so that it's not sharp when the needle goes through the skin. So you don't want to keep going in and out of the skin because that's what hurts. Once you're through the skin, then you can explore all sorts of different levels. But you withdraw it beyond the fascial plane, but not outside of the skin, and then redirect it. So that's stuff you will finesse one-on-one at the tables.
Could you repeat how you land at your gallbladder 31, please?
I land at gallbladder 31 by reaching his arm down to where he's touching the lateral side of the thigh. In fact, everybody can just stand up in a relaxed posture, and where your fingertip touches the thigh. Now, you don't want to be in the back of your hamstrings, back of your thighs. You don't want to be in the front in your quads. You want to be exactly lateral. Where that middle finger touches your IT band, that's your starting point for where gallbladder 31 is. It's a lateral point. Gallbladder channel is a lateral channel, lateral aspect of the body. Does that answer your question okay? All righty.
Interesting sensation after gallbladder 31 went in. That whole hemipelvis on the left got warm, even radiating anteriorly. So like it all warmed up and seemed to relax after the needle insertion.
We're kind of rocking his world. You can imagine doing a prone treatment on someone and then rolling them over, checking the transversus abdominis, checking the stomach 30, and seeing if you can get more release after this is done. So you can see how these can build upon each other and sequence with each other. Great.